The other thing that probably didn't appear on my CV, which is full of a variety of different details, is that I got an MPP at Kennedy School at Harvard, joined MD MPP. There's someone in this room, I can't remember exactly who is doing that. And I spent 7 years on the faculty at the Kennedy School.
I forgot about that.
Yeah. And was the executive director of the Center for Health Policy and Management at Kennedy School for 5 or 6 years, and a lecturer in public policy. So I got very comfortable in your sister institution up in Boston.
It's a very fine institution.
So this brings back having all these public policy students, and the interdisciplinary nature of this is very familiar. I also, for a number of years, ran an interfaculty program on health policy at Harvard, out of the provost's office. So it was my job to try to bring together folks from all over the university to work on health policy issues. A noble and challenging enterprise, especially at Harvard University. I suspect there would be a lot easier to do here, or Yale, or Princeton, or almost anywhere but Harvard University. Anyway, it's great to be here. It's great to have a chance to get outside of the Northeast. It was snowing this morning as I was leaving for the airport. And I can see the beginnings of spring here, which is really, really encouraging.
It's a good thing you didn't come 2 weeks ago.
Yes.
The university was closed literally for 3 days.
I heard rumors of that. So I'm going to talk about, as I was explaining to Tony, I'm going to dive into healthcare, which I know a lot more about than I know about philanthropy. But I'm going to resurface later on to talk about the Commonwealth Fund's agenda as it's been shaping under new leadership over this past year. So my agenda is this. I'm going to, for those of you who don't wallow in the issues of healthcare day in and day out, I'm going to remind you of why it is that we're so tied up in knots trying to make things better with the Affordable Care Act. It's not just a whim or a kind of lark that we've gone down this difficult path. There are reasons why we've done it. I'm going to talk about the really fundamental choices that we face as a polity about what to do about our healthcare system. Then I'm going to talk about some of the next steps that I think are taking shape, and the new legislation, the Affordable Care Act, is very much a part of the choices that we are making and offers additional choices. Then I'm going to talk about what I think is a growing national consensus, actually, about what we need to do on the side of the delivery system, the care delivery side, as opposed to the insurance side. And then I'll talk about the Commonwealth Fund agenda. And that'll all take me 10 minutes, and then we'll be done. Our healthcare system is profoundly broken. I don't think those of us who are fortunate to be well insured and to be in areas like Raleigh-Durham, where there's a very strong healthcare institution, are aware of how broken it is. But for many, many Americans, it's broken, and for us as a civilized nation, it is an extremely, almost shameful aspect of our national institutions. Whether you look at the cost of care and the wasteful spending that goes on, some of it actually not just wasteful but dangerous, whether you're talking about our record in terms of quality of care, or whether you're talking about the equity of our health system, by any standard, we perform poorly by international comparisons, and we perform poorly by any reasonable standard of performance. So the first and most obvious thing, which one forgets now that you hear every couple of weeks about who's enrolling in the Affordable Care Act and the expansions of Medicaid, which are happening in some states, not this state, but some states. It's easy to forget where we are still at the dawn of the Affordable Care Act. We have had year on year on year, increasing numbers of uninsured Americans. As you can see, from 2003 to 2012, the numbers of uninsured adults in 1964 increased from 26 million to 30 million. Some are uninsured at some time during the year, some are uninsured at any particular time. The combination of those is about 30 million. The reason, and one other point, and this is a contribution of the Commonwealth Fund. The Commonwealth Fund formulated a definition of underinsurance, that is excessive costs imposed on insured people, that is defined as greater than 10% of their income in a given year spent on healthcare despite being insured. If you look at that number, it comes to about 55 million Americans. So the combination of uninsured and underinsured in the United States comes to about 85 million. You may know of a country that has a population of 85 million. It's called Germany. So nested within the United States is a country the size of Germany that is not protected against the cost of illness. And when you put it that way, I think it reinforces the reason why we couldn't just continue down the path we were on prior to the Affordable Care Act. And this is one big reason why uninsurance is a problem and would continue to be a problem. The upper lines here, the upper two lines are rates of increase in insurance premiums and workers' contributions to insurance premiums. The lower two lines are CPI and rates of increase in GDP. Now, if any of you were in business selling the product which is being purchased according to prices on the upper line, you would be in deep trouble, because it would be very clear to you that, by the way, I think that you are involved in that product, it's education. So, and I think the President has made clear to educational institutions that they can't continue on the same path. There are a lot of similarities between health and education that neither constituency is very proud of. But this is a prescription for a non-saleable product. And in fact, that is the reason why year on year, the proportion of uninsured has been growing, because people can't afford to buy insurance. And not only that, but when they do buy it, its expense cuts into their ability to buy other things, with the result that wages, effective purchasing power on the part of American workers suffers to the extent it does. And one of the reasons, I believe, for the inequalities that we have in income has to do with the fact that we devote so much of our workers' income and wage benefits paid to workers to health care in this country. Now, if we were getting a return on investment for that, it would be great, but we're not. The population of the United States, for any given level of education or income, is less healthy than virtually every other industrialized nation in the world. So we spend all this money and we are less healthy. We have shorter lives and we have more morbidity. So it's not just a matter of wealth differential. Some of it is undoubtedly behavioral. We have high levels of obesity. A little bit of good news in the New York Times or in the papers today, but that's only for a very small segment of our population. We have high levels of obesity, but we have much lower levels of smoking than many of the populations to whom we compare. So if you look at France or England and look at the proportion of people who smoke, many more people smoke in those countries than in the United States. Some of the work we do at the Commonwealth Fund, in our intramural research, is we track performance by geography of different sectors, different parts of the United States. And we use nationally collected, consistent data that enables geographic localization of statistics on levels of performance and levels of health of our healthcare system. And this particular chart is actually tracking performance at a local level, not a state level. So So there are 306 hospital markets in the United States that have been identified by the Dartmouth group. And you can get data on about 30 or 40 indicators of health and healthcare system performance at that level. And if you look at the top performing localities and the low performing localities, this is what you see. The low performing localities are in blue, and the top performing are in kind of the I don't know whether that's ochre or wash yellow. This pattern of performance is pretty consistent over time. It also shows up when you look at on a state-by-state level, which I'll get to in a moment. Northeast, Upper Midwest, Northwest have the best performing healthcare systems in the United States. The Southeast
How do you define performance?
about 30 indicators. They have things like mortality amenable to prevention. There's sort of a bunch of health statistics. One of the more interesting ones is the frequency with which older people are prescribed drugs that are contraindicated for the elderly. So it's a nice quality metric. The proportion of people who report that they can't afford to purchase health care because of the cost of health care. So we have about 30 such indicators that are available through national surveys that provide sufficient sample size so you can localize a performance level. Yeah.
So something that sticks out to me is it looks like in parts of the country, the urban-rural does impact performance, like Raleigh, Durham, Houston, Chicago, whereas other
Actually,
areas.
that's Austin.
Oh, Austin.
Yeah.
Whereas others, the Midwest, probably very rural areas with still high-performing systems. Like, did something stick out that would explain that difference?
So we don't understand all the reasons for what we observe, but we do observe this pattern, and you can speculate on what the differences are. I think that the little patches of yellow in the seas of blue simply tells you that geography is not destiny. That there's nothing about Florida that condemns all of Florida to having a poor performing health system and low health status. And I think the next set of research, if you were going to do it, would be trying to define what the correlations were, and we could all speculate. One of the interesting things is that if you look at performance with low-income populations, the same general pattern persists. I like to show this slide because what it tells you is that if you're a low-income person in a high-performing system, high-performing area, you actually are likely to have better health than a high-income person in a low-performing area. So you're less likely to be prescribed as an older person a drug you shouldn't be prescribed if you live in the Northeast or the mid-North Central United States than if you live in the Southeastern United States, and even if you're poor. So what it tells you is that having low income doesn't condemn you to bad health care, and having high income doesn't assure that you'll get good health care in the United States. So this is just one way of sort of illustrating within this pattern of high expenditure, low overall quality, and lack of insurance, that there are these enclaves of high performance and low performance that really create more than one America. I'd say there are really two Americas. There's the Southeast and the Southwest to some degree, and there's the Northeast and the mid-upper Midwest. Now, it's an Olympic time. If there were competition, international competition for healthcare expenditures, the United States would take gold, silver, and bronze, hands down. There'd be no competition. As a matter of fact, we'd probably take gold, silver, bronze, lead, copper, everything. So this is the top blue. The top line here is the United States, and these are other OECD countries, showing both total expenditures as a percent of GDP over time and total expenditures per capita in US dollars. And there are such enormous differences between the United States and every other country we would normally compare ourselves to, that it's absolutely striking. And there is, this is one of the things that Americans, I think, know intellectually, but and I'll show you some data about what it means actually to be spending at this level in terms of lost opportunity. So this system we have, which is such a wasteful, low quality, unfair system, really poses some very important choices for us. Now, it so happens that we are in a period with respect to cost of relative moderation. And no one knows exactly why, but the last 2 or 3 years, national health expenditures have been going up at a lower rate than in the last 50 years. We can talk about why that might be, but it's an interesting question. But were those expenditures to resume their 50-year historical rate of increase, we would clearly not be able to afford them much longer. They are impinging upon other things that are critical to our national welfare. The ability of workers to spend money on other things, the ability of state governments to fund infrastructure, to build roads, to fund higher education, to provide food for people who can't afford to provide food for themselves. Actually, President Obama said not so long ago that we don't have a federal deficit problem, we have a healthcare problem. And that's the extent to which I think there's now realization that we cannot sustain government in its current form with the levels of healthcare spending we have. So what choices do we face? How do we deal with this? Well, one way is to essentially take away care from people who have insurance, or not provide insurance to people who have it. So one way to do this is to raise co-insurance and deductibles. So high deductible health plans are now very rapidly spreading within companies, within industries. What that amounts to is de-insurance, right? It amounts to taking away the value, reducing actuarial value of the insurance product. Or you can say, we used to insure people for at age 65 for Medicare. We're going to move that to 67 because everyone knows that the 65 is now the old 55 or 40, right? So we're all very healthy at 65-year-olds. We don't need the public to guarantee our health. It so happens that won't save us any money, but it does take away something from people who are expecting to be insured. Or you can reduce, as often is the case, you can reduce Medicaid benefits. And that happens quite commonly. So that's one strategy. And that is a form of rationing. It's not, the R word is not applied to it, but it's a form of rationing. The other way is to simply get more for our money. To improve the performance of our health system so that for every dollar invested, we get more health benefit, more services, more value from those services. Now, if you, almost anybody, given the choice, would say, oh, I'd rather get more for my money than give up something, right? So it's a pretty obvious choice. The trouble is, how do you make it happen? How do you take this system we have, which I would remind you, I may have this slide in here, I can't remember. If you put our healthcare system on an island and floated it out into the Atlantic and called it the U.S. healthcare nation, it would have the 5th largest GDP in the world. Larger GDP than France or England, almost as large as Germany. So when you say we need to reform the U.S. healthcare system and make it more efficient, it's like going to France and saying, make your industrial sector, your economy more efficient. We know how good the French are at doing that, and how easy it is to make that happen. It's a big, complicated project. So one way that I have of thinking about this within the context of the U.S. is to think about healthcare performance in terms of the interaction of what I call microsystems and macrosystems, which interact with one another and also directly impact performance. So what do I mean by microsystems and macrosystems? Microsystems are where people who deliver healthcare, like as I did for most of my professional career, a physician's office, a hospital floor, an ICU, an OR, an emergency department, a home care agency, a outpatient clinic. Those are places where people and caregivers come together and decisions are made and resources are allocated, with the consequence, when you add that up over billions of decisions at the sharp end, result in the products that we are so concerned about, the level of performance of our healthcare system. So that's the sharp end, the microsystems in our healthcare system. And that's where most of you as receivers of care experience the health system. It's where most of us who provide care experience the healthcare system. But it's not all that matters. In fact, most systems theorists would argue that performance is much more influenced by macrosystems than microsystems. So what are macrosystems? Macrosystems are probably where folks in this kind of institution are most comfortable. And that is the big policy and regulatory and institutional forces that govern behavior, that influence behavior from the outside. There are things like public policy, how Medicare pays for care, how Medicaid pays for care, the rates of payment, the expected returns in return for payment, the way we license professionals, what we expect of them, what competencies they have to have, how we license and certify our healthcare organizations, what standards they have to perform to. So these payment systems and regulatory systems and institutional cultures and characteristics are heavily influence what microsystems can accomplish. Now, most of us, when we think about healthcare, we think about choosing the right doctor. And as though the doctor, I would like to include nurses in that, but we don't usually choose a nurse. Most of us think that what really matters is getting the right doctor. But what doctors can do is constrained and influenced in very important ways by all these other systems in which they work. They don't have total freedom to make decisions that are in the best interest of their patients, and they are really limited in doing some things that are really important for their patients. So macrosystems are really, really important in terms of what level of performance we accomplish. Now, it so happens that we know a lot about microsystem performance and how to make it better. The best illustration I have of this is a paper that I wrote probably 25 years ago with a colleague. It was a review of the literature on something called reminder systems. Reminder systems are really complicated. Think about them this way. When my wife reminds me to do something, I'm more likely to do it. That's a reminder system. When I remind my kids to do things, sometimes they're less likely to do it. But anyway, it has a predictable influence. It so happens that if you remind doctors to do things, they're more likely to do it. We've known that for a very long time. There's really good studies in the literature showing that's true. If you want chronic care, people with chronic illnesses to be cared for properly, to get the right immunizations, to get the right checks, to be seen at the right intervals, just remind doctors and nurses to do it, and you will get improvements in performance. Now, did I have a reminder system in place when I was a primary care physician at Mass General Hospital? Well, I did toward the end of my time there, but for most of my time I didn't. And the reason I had it was that we had an electronic health record that made it kind of automatic. But most healthcare systems in the world do not have reliable reminder systems. The same thing could be said, by the way, of another influence here on the upper right-hand side, CDS, CPOE, computerized decision support, computerized provider order entry. Good literature, regularly reviewed, showing that if you give decision supports electronically to clinicians, their performance improves. Now, did we in 2008, 2009, have widely available electronic health records? No. 7% of U.S. physicians, 17% of U.S. physicians, about 10% of U.S. hospitals have electronic health records in 2009. So, the question is, why don't we do what we know works? Now, I've sat around many tables, seminar tables like this, where the issue in front of us was, how do you take innovation and spread it? How do you get the adoption of new ideas that look like they could make things better, or may have proven in small trials or academic studies to be made better? And I submit that in healthcare, the problem is that we failed to create macro systems that encourage and support the use of microsystem improvements in such a way that those microsystem improvements have an easy time to spread. So there's another way to think about that. Fundamental delivery system reform means making it easy to do the right thing. In healthcare, the opposite is often true. We make it hard to do the right thing. A good example of that is and I know some of the folks around this table are very interested in readmissions. It turns out that we have relatively high rates of readmission within 30 days of older people, Medicare patients, and a lot of those are preventable. But it's not easy to get people to work on preventing those readmissions because that results in reduced revenue for the hospital. So the hospitals have no financial incentive. As a matter of fact, the hospitals have to give up revenue in our current system to do the right thing. The same is true of many other kinds of things that physicians and hospitals do. Doing the right thing means sacrifice. It means heroism. It means altruism. It doesn't mean you're rewarded for doing the right thing. That is not a sustainable way to support improvement. You can't rely on altruism and heroism on a daily basis from normal human beings and expect to get a change that's sustainable and substantial. So, which brings me back to the Affordable Care Act. What is relatively underappreciated about the Affordable Care Act, in all the loud controversy over the enrollment in marketplaces and the expansion of Medicaid, what's underappreciated is the Affordable Care Act is chock full of macro system reform interventions. It is probably the most important effort to change the performance of the health system, the efficiency of the health system, that we have ever undertaken as a country. Matter of fact, you could say that as a result of the Affordable Care Act, for the first time, our toolbox is now full to overflowing. It's so full, the people who wrote that law put so much stuff in it, so many new and interesting ideas, that it's almost paralyzing. And you don't know as a hospital administrator what to do first. So some things you have to do. So you have to report, and I'll talk about this later, on avoidable complications or healthcare induced injury. And you actually will lose money if you don't work on them. But you will have the option of doing something called bundled payments, where you take hospital and doctor payments or hospital and post-discharge rehab payments, and you lump them together and say, we're going to treat this as one big chunk of things instead of paying you bit by bit. And you're going to have to live within that bundle of payments, which changes the dynamic very dramatically. There are all kinds of other things. I won't go through them. One that's commonly heard about is the Accountable Care Organization, which is a kind of a shift toward what used to be called managed care in the 90s. There's a lot of stuff in there. And there's so much of it that if you're working on this day in and day out, it's pretty, it can be almost paralyzing. Because you've got so many things you could do and so many things you have to do. That's one reason why the Commonwealth Fund put together this report, came out a year ago, out of a commission that we have since discontinued, called the Commonwealth Fund Commission on the High Performance Health System. We put together basically a synergistic program of interventions that we thought, if you did them together, would be mutually reinforcing and result in substantial healthcare savings and substantial changes in behavior. Now, we weren't alone in that. At about the same time, a whole bunch of organizations, some bipartisan, some not, were putting out very similar reports. So the Bipartisan Policy Center in Washington, the Brookings Institution, the Center for American Progress, the Bowles-Simpson Commission on Deficit Reduction, they were all saying pretty much the same thing. And they had a series of recommendations, which, since you're not healthcare experts, I won't go through it in detail, but these are the themes that they came to consensus on. That we should change the way we pay providers, that we should change Medicare and the way Medicare is structured, that we should engage consumers and patients more in their care, that there were fundamental flaws in healthcare markets that needed to be fixed, and that particularly flaws that raised administrative expenses to very high levels compared to almost every other country. So, as a result, or at least in the wake of the Affordable Care Act, there's some good news. This type of institution or entity called an Accountable Care Organization, which is an organization that accepts financial risk for Medicare patients and other patients, has spread considerably further than I expected. There are now 360 that work with Medicare, covering about 5.3 million people. Some of them are saving money compared to what people outside of accountable care organizations are experiencing. So that's all good news. $380 million in savings generated by Medicare accountable care organizations and pioneer ACOs. Again, I'm not going to dive into the details here. We could spend the whole time talking about what an ACO is and what a pioneer ACO is compared to another kind of ACO. But the point is that there's an inkling of positive effect. ACOs are now widely spread. There aren't as many in the square flat states in the middle part of the country as there are along the coast. But there are more than you might have expected, and there are more coming online every year. So actually, one thing that you may not be aware of or have forgotten is that the Affordable Care Act passed in 2009. So we're almost 5 years into its implementation on the delivery system side. On the insurance side, the implementation is relatively recent, starting basically in October of this year. But we've had almost 5 years of implementing the other portions of the accountable care. Actually, it's 2010, not 2000. So it's 4 years. We now have all hospitals reporting publicly on the rates at which they injure patients. Hospital-acquired conditions, hospital-acquired infections, a very good example of that, infections that occurred as a result of something that was done to a patient in the hospital. We also have 50,000 healthcare providers working on innovative solutions to healthcare problems through a part of the Affordable Care Act called the Center for Medicare and Medicaid Innovation, which is one of the most important things that's happened in public policy in my lifetime. And we have this reduction in readmissions within the Medicare population, which has occurred at the same time that the implementation of the Affordable Care Act occurred. So instead of a rate of 19% of patients discharged being readmitted within 30 days, we are down to slightly less than 18%, and it's continuing to fall.
But this, so Dr. This predates even when penalties came into account, right? I mean, because
Well,
penalties.
some of it was anticipation, I
Yeah,
think. of
I
that.
see.
Yeah. So it's not the insurance, it's the hospitals, the macro system acting
Well,
different.
it is actually a change in payment. Basically, the federal government said, if you are readmitting people more than is expected, we're going to take away money. So it's pay for value, pay for performance, where the performance metric is the rate of readmission. Now, the other thing that I mentioned earlier, and that actually began before the Affordable Care Act became law, is this downward trend in rates of increase in healthcare spending. So from 5 to 6% annually to about 3% annually in national health expenditures per capita. And instead of being 2 to 3% more than GDP per capita, it's now about 0.8% more than GDP per capita. And that's the lowest rate in excess of GDP that we've seen in 50 years. Now, you pick one economist, you'll get a different, any economist, you'll get a different opinion about why this is happening. Two big camps. One is saying it's all about the economy. It's all about the recession. People don't have money, so they're not buying healthcare. And that has historically actually been true. When deep recessions have occurred, healthcare spending increases have slowed. But there are other people who say, yeah, but when our models show that when you take GDP into account, this change is much more dramatic than can be predicted by GDP change alone. And something else is happening. Not clear what it is, but something else is happening. I mentioned this before. This is just a graphic about U.S. healthcare spending. Even if we kept U.S. healthcare spending at the current level it is, we would still have this amazing phenomenon of having a healthcare economy that is so disproportionately sized in our country compared to any other country in the world. So there's a fixed cost to our current healthcare system, such that simply reducing the rate of growth is not sufficient to manage our problem. But more to the point, there's the opportunity cost of spending at the rate we do on healthcare. So what this slide does is it shows in the upper left-hand graphic what the U.S. healthcare spending would be now if it had increased at the same rate as Switzerland's spending starting in 1980. Now, in 1980, Switzerland had the second highest spending rate per capita in the world, so that was the point of departure. If we had increased health spending in the United States at the same rate as Switzerland, we would have spent $15.5 trillion less on healthcare over the last 30 years. So what could we have done with $15.5 trillion? We could have transformed our national debt of $11.6 trillion into a $3.9 trillion surplus. We could have sent 175 million students to Duke University free of charge. And maybe a few to Harvard, Yale, or Stanford. We could have increased spending on public health and prevention by 20,000%. And we could have bought 4 iPads for everyone in the world. So,
Apple stock.
yeah, Apple stock, if you own it, you'd be very happy with it. So this is some of the, this is a way of thinking about what you give up when you make a decision to spend money a certain way. Now, going forward, if we maintain our current level of rate of increase in healthcare spending, if we're able to sustain it over the next 8 years, 6 years, 7 years, we would save a lot of money. We'd save $770 billion in public sector spending alone. So that's the opportunity going forward. $770 billion that wouldn't be spent by the federal government on healthcare. You have a question?
Yeah, so regarding the cost increases as budding economists.
Regarding the which cost?
Cost increases?
Yes.
I'm going to posit another idea, and I'm curious what you think. Due to or is it the kind of decrease in cost that Europe is able to realize by just telling providers and suppliers, we're not paying more than this, and this is it? Do you have any idea which one might be?
So it's a very big and important question. Can you make healthcare function like a regular market and make consumers price and quality sensitive and discipline the system through consumer choice? The answer is theoretically yes. Practically, it doesn't happen. So none of this change, I think, can be attributed to consumer sensitivity. Part of it may be that people are buying less because they have these very large deductibles. But it means that they are not, usually when they make decisions not to buy things, they don't distinguish between things they need and things they don't need. People are not very well informed about what they need as opposed to what they need. So all the studies that look at the effect of high deductibles on healthcare consumption show that the result is that people forego things that are really cost effective and things that are really cost ineffective in equal measure. Time check. We're fine. We're going till what time? Midnight? Is that when we're going?
Yes. Say halfway midnight.
Halfway. Because I haven't gotten to the Commonwealth fund yet.
We should be fine.
So the question is, does the moderation in national health expenditures that we've seen in the last few years, which is very encouraging, mean that things are fundamentally different? And my view is that with the sunk cost we have, in order to realize our full potential in education, in culture, in infrastructure spending, all the things that we are economizing on right now, that finding money in healthcare is probably going to prove absolutely essential. That we can't, that spending 18% of GDP on healthcare when the nearest competitor country spends 10% is probably not a way that we want to go into the future. So just limiting rates of increase to 0.8% more than GDP is still not a sustainable or healthy level of spending on healthcare. So whether we can keep whether we can sustain this more moderate rate of growth, or whether we can create a high-performing health system, really is a matter, I believe, of collective decisions about how we structure mostly the macro systems that we're engaged in trying to affect right now. We do know a lot about microsystem reform. We can do better than we know, but if we just implemented what we know, we'd have a much better health system than we currently have. So just a little bit about the Commonwealth Fund. This is all about, in some ways, motivating what we do at the Commonwealth Fund. So our mission, the reason I use the wording I use is because our mission is to create a high-performing health system in the United States, and one that particularly is high-performing for vulnerable populations, which are, we define mostly as low-income and ethnic and minority populations. The Commonwealth Fund, as Joel said, was created in 1918 by Anna and Harkness.
Thank you.
It had a very broad mission through most of its life, but about 30 years ago it focused down on healthcare. And that healthcare mission, as I said, is about a high-performing health system. Now, our current agenda, it reflects a strategic, what we call the strategic refresh that we did over the last summer, and resulted in our board approving a new strategic direction that has the following areas of emphasis. And I apologize for those of you who aren't in the healthcare world. Some of these words may not have a lot of meaning to you, but I'll try to illustrate some. So we have four major priorities. One is healthcare coverage and access. Say a little bit more about that in a moment. The next is healthcare delivery system reform. The third is using lessons from international policy and practice to help inform change in the United States. And the last is something called breakthrough opportunities or breakthrough healthcare innovations, where we essentially are saying, are there some changes which, if implemented widely, would create discontinuous, disruptive, fundamental changes in the performance of the healthcare system. Not things that would improve healthcare performance by 0.5%, but by 20 or 30%. And in addition to that, we have a number of what we call special initiatives that in some ways support the other four priorities. One is work on cost control, another is work on Medicare, a third is the tracking that I showed you some outcomes of. And we do a lot of work with policymakers to make sure they know what we're doing. So healthcare coverage and access. Our goal is to maintain and enhance the Commonwealth Fund as a source of relevant, timely information for people implementing the Affordable Care Act at the state and national level, and to actually be of practical use to folks who are making decisions day in and day out about how to make the Affordable Care Act work, both on the insurance side and on the delivery system side. We do that through research, data collection, and policy development. We like to say that our goal is to have the right information at the right time delivered to the right people the right way. And that's how we want to distinguish ourselves or judge our performance. In the area of delivery system reform, we made a decision that to focus our effort. Some of you, the folks I've spoken to here, have commented on the fact that the Commonwealth Fund has a very narrow mission, working on healthcare. But if you think of healthcare as an economy the size of Germany, or nearly so, it's not such a narrow mission, it's a big job. And so the question is, how do you focus for impact on this delivery system that extends from the Bering Straits to Key West, and of course, don't forget Hawaii, and has billions of interactions between individuals and professionals every day, not every day, but throughout the year. So we decided that the way to start was to focus on certain populations and make sure that the system was working for those populations. And that if we did that, we could extract and define lessons that would be broadly applicable. So the two populations we focused on are what we're calling high need, high cost, which I'll explain why we're doing that in a moment. And the second is vulnerable. The vulnerable population is more of a kind of historic value-based commitment. The focus on high need, high cost is because of this phenomenon, that the sickest 10% of Americans account for 65% of healthcare spending. If you don't find a way to manage the costs and performance and quality of care for those patients, you will never be successful. And they have distinct needs. They're not a homogeneous group, but within that 5 or 10%, there are very distinct groups that have very definite needs, and the healthcare system, to perform well, has to acknowledge and respond to those needs. It has to be organized to address those needs. So a healthcare system that works well for a 25-year-old runner is not the healthcare system that works well for a 95-year-old homebound woman with diabetes, hypertension, congestive heart failure, chronic obstructive pulmonary disease, and dementia. But it's the latter patient who is in and out of our hospitals, in and out of our emergency rooms, takes 10 or 15 medicines, and has 5 or 7 physicians, and whose care is not coordinated, and whose family is burdened with making sure that she, and it's more likely to be a she, is hanging on day in and day out. So I'm not going to go through this because time, I want to leave the questions. There are a bunch of models for taking care of high need, high cost patients. They're not all the same model because different models serve the needs of different populations. This gets at this microsystem issue. We have developed microsystems that are very good at caring for that high need, high cost patient. One that I'm particularly familiar with is the second down on this list, Commonwealth Care Alliance. Commonwealth is not Commonwealth as in the fund, but Commonwealth as in the Commonwealth of Massachusetts. And this is about a 15 or 20-year-old model in which cares for what's called dual eligible population. These are poor people who are who are eligible for Medicare, and their poverty makes them eligible for both Medicaid and Medicare. They are very sick. This particular group also is a group that has disabilities. They're often homebound. This actually Commonwealth Carolina started caring for AIDS patients and then expanded into caring for dual eligibles more generally. They get a single lump sum payment every year from Medicare and Medicaid to care for each of their patients. They don't bill fee for service. They are what's called capitated, and they have to live within that budget. And the result is that they not only do it, but they make a substantial amount of money. They're non-profit, but they have retained earnings. And one of the things they've decided is that the dual eligibles they're caring for who have behavioral health problems, mental illness, substance abuse problems, need housing often more than they need medicine. So they've actually just bought a housing arrangement. They bought an apartment building where they're going to make sure that their homeless mentally ill patients have a place to live. This is a healthcare organization, but it's made a hard-nosed decision that it can keep people out of mental hospitals where they pay $2,400 a day for care by buying apartments where they pay $1,000 or $500 a month for a place to live. Why isn't that spreading? This is a proven, well-documented success, not spreading. We need to make sure that these kinds of ideas do spread. We also have programs related to the vulnerable population. We have a fellowship that trains minority health professionals to be healthcare leaders. They spend a year taking seminars and getting an MPH at the Harvard School of Public Health. We also do a lot of targeted studies around the care of low-income populations in federally qualified health centers, in safety net facilities, in Medicaid managed organizations, and a set of arrangements that are particularly oriented to those populations. One of the things that's most fun about my job is the international work we do. Almost no one in the United States, aside from us, does an appreciable amount of cross-national studies in healthcare. When I was on the other side of the table and my job was to beg for money, I knew enough not to beg for money to study international health, except in Commonwealth, because there was basically no one who was paying for it. You can't get the NIH to give you money to study international health. You can't get the Robert Johnson Foundation to give you money. No one will give you money to study international health, except the Commonwealth Fund. And we actually mostly do intramural and contracted work in this area, because it's very hard to get, because there actually aren't that many people who are interested in doing it. We are pursuing transferable international models. We have a lot of experience over about 20 years doing international, cross-national studies. We have deep networks in a lot of Western countries. And we're focusing more now on practical transferable models than on system innovations. And there's a simple reason for that. If you try to bring a systemic change from abroad to the United States, it gets stopped at customs and sent back. There's just no way in. So it's all socialist. It all comes from one of those socialist countries. So it never has a chance in public policy forums. So we're testing the hypothesis that if we can get under the radar of policy and get information into the hands of professionals in the context of changed economic incentives, that there may be an interest in learning from abroad about things that actually make a difference to patients. But we'll see. We have a fellowship program where we bring about 16 mid-career scholars or practitioners from abroad to study the U.S. healthcare system for a year. They come from about 8 countries. And I just finished my first ever participation in this election. Went to New Zealand, Australia, Sweden, the UK, Germany, the Netherlands. So we have about 8 countries that bring fellows, and Canada, so we also have Canada fellows. And we now have about 200 spread around the world of these Harkness fellows. Some of them have become quite important leaders in their respective countries. The new head, starting April 1st, of the National Health Service in England is a former Harkness fellow. The former Director General of Health in New Zealand is a former Harkness fellow. The former head of NHS Scotland is a former Harkness fellow. So we have, for some reason, people in these other countries think that learning about the U.S. healthcare system seems to be a qualification for leadership. I think I would re-examine that hypothesis. Actually, if we have time, I will say some more about that. One of the things that we're trying to do is use our 200 alumni as our eyes and ears around the world. These are people who live in their systems, they know what's going on. We use the London School of Economics actually as a kind of organizing contractor to tap them for reports on what's going on. And we do every year a cross-national survey of the condition of healthcare in 11 countries, which has become an incredibly important tool almost everywhere but the United States. So if you want national data on the performance of the UK's healthcare system, you actually go to look at the Commonwealth Fund survey. If you want national data on Canada's healthcare system, you can find it from Commonwealth, but you can't find it in Canada because Canada actually is a provincial system. Each state, province in Canada runs its own system, and there is no real federal programs, and there's no source of cross-provincial data in Canada except our survey.
It's really provincial.
That's right. I mentioned a breakthrough opportunity program. This is an experiment for us. We're not doing what a number of other very, very able foundations are doing in terms of, for example, impact investing. We're not supporting apps. We're not being venture capitalists in healthcare. We're trying to think of whether there are some fundamental changes that may not be exploitable or may not be interesting to folks that have a very short-term financial orientation. So I don't know the name of the graduate student in the back who asked a question about empowering consumers. But one of our hypotheses is, and this partly reflects my personal experience, 35 years seeing patients as a primary care physician. I practiced at Mass General. I had a lot of Harvard professors in my practice. So IQ was not an issue in terms of whether
ego or ego.
Ego or ego, right. But I found that when they sat in front of me, they regressed to a very passive stance with respect to their care. They'd come to see me because they thought I was a good doctor, and they wanted me to tell them what to do. And I don't think that's a totally irrational position to take. It's what actually most of us want. It's what I want from my primary care physician. I don't want to tell my primary care physician how to treat me. I want to get out of the way of an objective individual whose knowledge and I trust. And so the question is, can that dynamic be changed or modified in any way? Is there a way to in a constructive, positive way, to make consumers better at making decisions in ways that would discipline our healthcare system? The only thing I can think of that has the potential to do that is the world of mobile apps and electronic communication. So we have technologies now for informing people, for getting information in front of people at critical times in their lives. That is unprecedented in the history of humankind. And so one possibility is that IT-enabled consumers could be more powerful in healthcare than they've ever been before. Now, the missing ingredient in this soup, if you will, is information that's actionable. So if you give people an iPhone right now and send them into their physician's office, it's great that they have an iPhone, but there's no information you can deliver to that iPhone that will accurately inform them about the decisions that their physician and they have to make together, and make them capable of either questioning or informing those decisions. There is a lot that people know about their health care, and their involvement in their health care is a positive. It's actually empirically been shown that when patients are engaged, they do better. But our ability to change that asymmetry of information in real time on a mass scale needs something new, something more powerful than we've ever had before. And the question that we're exploring is whether IT has that capability. And I think in particular, we're asking that question about the high-need, high-cost patient. One of the things in my several years as what was then called the IT czar in the federal government, I saw a lot of people with new ideas for IT applications. A lot of them were about 40 years old. They were male. They were engineers. And they were, frankly, clueless about healthcare. Their idea of an app was, a pedometer that, Fitbit, that shows you how many paces you've done, or maybe what your heart rate is, or maybe you could do an EKG on you remotely. Most of you sitting around this table do not need an EKG right now. You just don't. It's not a very useful thing to have. It sounds good, but it just doesn't. Now, so marrying IT to the needs of a population that really need healthcare and need to make better decisions is still a bridge too far. And the question is, and its payoff is uncertain. So it's unlikely, I think, that most venture capitalists are going to dive into this very soon. So we're thinking about that. We believe that incentives in the healthcare system are broken, and the current approaches to incentives, especially on the provider side, are far from ideal. So we're exploring particularly the application of behavioral economics, not just to consumer decisions, which is where it's currently fashionable to apply it, but to provider decisions. We have an advisory group of smart people, some of whom are venture capitalists, who are trying to help us sort through this. Developing a surveillance process for these opportunities is, in some ways, and an evaluation process is really our critical challenge. Cost control, we have a neat new group of a council of economic advisors that is helping us think about new cost control opportunities. I'm not going to say a lot about that. I think we are trying to continue to work on creative solutions to Medicare's problems. Medicare is approaching its 50th anniversary. You can begin planning the party now, before you're planning parties. 2015, 50th anniversary of Medicare. It's less than a year away. It's actually July of 2015 if you want to get technical about it. But we think it's an important opportunity for us to focus attention on how Medicare can be preserved and made better. Now, I mentioned scorecards. I illustrated a few of them. We're continuing to do that. We think our scorecards actually may be a very interesting way of tracking the Affordable Care Act's impact on healthcare, and also state-to-state differences. Since we have 30 to 40 indicators of performance on every state, we have them over the last 7 or 8 years. The question is there going to be a change, and is the change in performance going to vary depending on whether states implement marketplaces aggressively, implement Medicaid for them. We are very interested in being available to and useful to policymakers. This coming weekend, I'm going to be in Houston for the weekend. We have an annual bipartisan congressional retreat. This year we have about 20 members, 17 congressmen and 3 senators coming to spend the weekend with us in Houston, and we are going to delve deeply into healthcare issues, the Affordable Care Act performance, end-of-life care, because there are a number of congressmen who are interested in bipartisan legislation in managing end-of-life. It seems like we've put death panels behind us. We do briefings for congressional staff. Last week we had a retreat for congressional staff. We actually also work with the National Governors Association and the National Council of State Legislatures to provide information and provide a channel of, create channels of information flow to those constituencies as well. We have a very active and effective communications group. I've worked over my career with a number of communications groups, both in universities and in hospitals. I ran a communications group at Brigham Women's Hospital for 4 years. We called it public relations in those days. I think that the group we have at Commonwealth is the best I've ever experienced, worked with. And one of the things we're very much involved in right now is reorienting our communications to the new world of social media. We actually have goals in social media about increasing our Twitter and Facebook followers and friends. I'm now on Twitter and I tweet. I find that not only is it enormously valuable to me to see what the conversation is on Twitter about healthcare issues, but that we can magnify the numbers of users of our material by bringing it to the attention of people on Twitter. And the fastest growing area, as a matter of fact, we have an email list. That email list has stopped growing. All our growth in people attentive to our issues is in social media. And we see that as the future. And we have an evaluation and measurement program which we are implementing. We have always done evaluations at the Commonwealth Fund, but we're now trying to develop outcome measures for particular programs, not as standards of judgment, but as disciplines for thinking. The idea being that if you know where you're going, as Yogi Berra said, you're more likely to get there. So if you know what changes in the world would be consistent with your mission, it's easier to design programs that will get you there. And if you don't go through that process, that discipline, then you have to consciously, I think, step back and say, it's okay if you fail. It's okay if you don't accomplish these goals. We're in the risk business. We're in the experimentation business. Anyone who does research knows that failure to prove a hypothesis is not a failure. It's part of it. And so if things we are doing don't work, that's just a reason to change direction. So I'm done. I went longer than I thought, but that's because I gave actually 3 talks. But I appreciate your attention and delighted to be down here. Look forward to any questions you may have. No questions.
Yeah, I have really 2 questions, but I don't think they invite very long responses. The first is, I'm assuming and hoping that the decline in readmissions has not been accompanied by an increase in mortality.
Actually, mortality, health in the United States is improving. Not as fast as you'd like, but it's improving.
The other is the point up there about paying for value rather than volume. I'm assuming it's easier to document volume than it is to document value.
You're absolutely right. And that's why it's hard to do, pay for value. We have primitive measurements of quality. I actually chair a committee for the Institute of Medicine and the National Academy of Sciences on what's called core metrics. And that's an effort to come up with a parsimonious list of essential measures of quality that could be widely used. And the need for that is another story altogether. That is a need for a parsimonious list. But we have some measures. We know that when we use those measures, they change behavior. So there have been a series of measures that have been used for public reporting of quality over the last 5 or 6 years. And the improvements on those measures has been so dramatic that they actually need to be retired. They're no longer informative. They are things like giving aspirin to people who are having heart attacks, or discharging them on the appropriate medications, or giving people with congestive heart failure particular medications, or counseling people about smoking when they're in the hospital. So these measures, which were promulgated by the federal government and by the accrediting bodies for hospitals, have been in place now for, as I said, somewhere a little short of 10 years, and compliance has gone from maybe the mid-60s up to the high 90s. And it's really not interesting anymore to trackers. So we know that that paying for value works, doesn't always work. And that's one reason we're interested in incentives, so-called incentives 2.0. Can you get a comprehensive view of value? Do we have that can we measure the special sauce that differentiates good care from not so good care? No, I don't think we can yet. Are there dangers to measurement? Yes. There's always the danger the measurable will drive out the important. There's also the problem, if you can't measure it, you can't act to improve it. So we're in if you're interested in social change as a strategy, I think one important element of social change is the concept of continuous improvement. And if you don't get started, you often never get started. So we're using the imperfect measures we have, which galvanizes the folks who are being measured, to tell us all the ways the measures are bad, and then you can turn around and say, well, help us develop better ones. And that gets a positive cycle going rather than just sort of paralysis.
Yes. I was interested in your example of the hospital that's paying to house people who are chronically homeless. I ran a homeless shelter in New York City and also in Indiana, and I ran a statewide advocacy organization for low-income people in Indiana. And it seemed to me that oftentimes policies working around people who are low income tend to be either punitive in nature or tend to be, how do we get this problem out of the public sight? And so I guess my question is, to what degree does class play a role in the healthcare issues that we're seeing, and how would that end up affecting some of the things that you're trying to implement? Another example would be here in Durham. There's something called Durham Connects that has said, we're going to get a nurse to every child born in Durham. And most of the time the nurse says, child's doing great, sounds great, we'll see you later. When the child is having problems, they make a lot of different referrals, get the child with the resources they need. But because it's done to every child, it's widely accepted in the community. They found, and the Center on Child and Family Policy here has found that it saved at least $3 million over the time it's been implemented in the last 5 years. So again, my point is that when healthcare says, okay, we're for everybody, it seems to be acceptable, but oftentimes when it's when we have these problems that are for low-income people, then it's ignored or...
So this is not, I was going to say these are not exclusively low-income, but for this particular program, they are dual eligible, so they're Medicaid eligible, which means they are low-income. The same problems affect people who are not low-income. You know, the chronically mentally ill substance abusers often spiral down into poverty, but they may not be poor initially, or they may have families who are capable of paying for them. These programs, well, let me say this differently. Healthcare has huge numbers of programs and huge expenditures that are devoted entirely to the poor. So we haven't had trouble mobilizing resources to care for the poor. We have a system of thousands of community health centers around the United States. Congress loves that program. They've expanded it repeatedly. So there isn't a resource constraint on healthcare. There isn't a lack of political support, at least in many parts of the country, and not at the federal level. What there is a problem of affordability. And when I talk about the Commonwealth Care Alliance, which is actually not a hospital, it's a physician-led group that doesn't have a hospital. It's just a bunch of doctors, primary care physicians mostly, and community health workers and nurse practitioners. What they've found is that there's so much money going into this population that there's plenty of money left over if you manage the care well to do these other things. As a matter of fact, the cost of the care drops dramatically if you take care of these social needs. One of the tricks to this, I believe, and I can't prove this, but I believe it's true. If we could take 3 or 4 percentage points of GDP that's going to healthcare, so let's say that for the 18%, if we said let's make it in that 18%, let's take 3% of GDP and focus it on social needs, but do it as healthcare, we could probably make people healthier and reduce total costs of care. And that's what this group is doing. I'd love to see that happen more, because I think you can get people to spend money for health care and let doctors distribute it when they would never allow the same money to be spent for that purpose if it were not spent by a doctor. So when a doctor prescribes housing for a patient, it's a little less debatable. Or when the doctor prescribes an air conditioner or a vacuum cleaner for an asthmatic, or a home visit for a newborn. So I think that's sort of a little crease of opportunity in this area that I see. And I think it's more of, I wouldn't think of it as a class-sensitive issue so much as as crossing an unwritten or an informal boundary that we have as a society between feeling comfortable with healthcare expenditures and non-healthcare expenditures. We're quite willing to throw trillions of dollars at healthcare, and we are niggardly on food stamps. So, there are some people whom food is a medical requirement.
Well, we normally try to stop about now, but if anybody has any last question, I'll be glad to do it. George.
There was a study, and I'm guessing you're probably familiar with it, that came out within the last month or so that was looking, it was either Washington or Oregon, that was analyzing this lottery system that they did to expand Medicaid. And I think one of the troubling things, or at least the summary points that came out of that, was the fact that expanding Medicaid for that group didn't in fact improve their utilization of care, meaning that instead of going to their primary care physician, they went to their ER more. And for folks like myself that are kind of on the front lines of not necessarily the advocacy piece, but talking with people about their decisions, I mean, what is it that you make of that, and how do you think in a state that's struggling in that conversation of expanding Medicaid, what do you think is going on there, and what kind of implication does it have for states that really want to expand Medicaid because they think of it not just as kind of the values, like the value statement of wanting to provide care, but also trying to still make that economic argument about the impact that expanded Medicaid can have?
So it's a very interesting study. The results were not at all surprising to me. There's very good information on Medicaid's positive health effects. So let's put that aside. So if you're interested in improving health, and if you think there's some connection between health and productivity, for example, health and being able to sustain work, then Medicaid may, through that group, Medicaid expansion may have economic consequences. But the accounting problem is that those aren't totaled up against healthcare spending. What you did in that circumstance is you said, let's give people the money to buy care, but change nothing else about the healthcare system. So they didn't have a primary care doctor before, for the most part. And you're expecting them to find one and learn how to use that primary care physician in the first year. Oh, and by the way, most primary care practices are not open 24/7. So if you have needs off hours, you're going to end up in the emergency room.
Or they don't take those patients.
Oh, they don't take them. Many of them don't take Medicaid. So we have what I think of as a really vestigial primary care system in the United States. We have 1/3 to 1/8 as many primary care physicians per capita as most other industrialized countries. It's really impressive when you see those numbers. So we have this totally dysfunctional, almost in many places non-existent. I mean, you can't get a primary care physician in Boston. I'm constantly pleading with my former colleagues to take, friends, family, whatever. And I think that's true in many parts of the United States. So the idea that you could just sort of give Medicaid patients money and expect them suddenly to be effective users of primary care, I think is naive. So they got more of what they knew of what they could get more of, which is urgent and emergency care. It's also what they were used to doing. And it's open 24/7. No appointments needed. So it works a lot better than our primary care system. It's not good at giving primary care, but it works much better for access to it. It's a complicated message to get across, I think, so it's easy to sort of hack at this. There was another study out of the same group that purported to show there was no major health effects of expanding Medicaid, but conveniently ignored the fact that it had a major effect on depression, which is probably one of the leading causes of morbidity and healthcare expenditure in the United States. Very briefly.
Yeah.
This is the last question.
Before I came over today, I was listening to a presentation on the use of big data and read an article that came out of the Harvard Magazine about that also. And I was interested, you made an early comment about your use of sampling techniques. Are you looking to move to incorporate the use of large data rather than sample sizes to get at some of the anomalies that maybe you're seeing across populations?
So I'm genuinely curious and uncertain about whether big data, as it is defined in the commercial sector, is going to be applicable as we think of it, as we think it's applied to healthcare the way it's applied elsewhere. So, and I think a lot depends on uses. So if you're going to start ranking states by the quality of care they provide, you've got to have, or localities, you've got to have consistent and reliable and cross-state data that you can defend on empirical grounds. And so measures take a lot of work when you're really doing good epidemiology. The kind of indicators that are available through people's purchasing behaviors, their locations, how they move, you know, what they bought, what they read, what movies they watch, all that kind of stuff that people are using as big data for figuring out what ads to direct at you, or what should show up on your mobile phone when you go to the mall. You know, basically being used to affect your purchasing behavior. The consequences of getting that wrong are totally different than the consequences of getting it wrong in healthcare. It certainly is different at the level of trying to influence the behavior of healthcare professionals. So we're nowhere near being able to use big data at the point of decision making for healthcare. It may be that we will at some point in the future have indicators of quality or performance that originate in these vast troves of health-related information that are sufficiently correlated with some things we really know matter, that we can use them as proxies. But we're not there yet. I think the cloud, you know, we've been using big data in healthcare for a very long time. We have, you know, Medicare claims data. We use that commonly. We do a lot of epidemiological work. We're a lot more highly evolved as a data-based enterprise than I think some other sectors. Maybe I'm overstating that, but and certainly if you're talking about influencing the choices that people make for their own personal care, or the choices that providers make for people, I think big data has a long way to go to prove its value.
That's the last question.
Thank
Very
you.
last question.
Thank you. So I was going to ask more a little about the electronic health record and your experience with that, and this most recent question actually speaks to it even more, because this is a potential huge source of data coming from places like Duke and our peer institutions across this state even, that are all implementing the same electronic health record. And so, you know, we see that as a promise. The challenges that I've heard and seen, not only personally when you go to the doctor, but from the work that I do, is that the faculty are struggling with the demands of this electronic health record, and actually what it takes away from their, you know, couple of minutes that they have with any one patient in the doctor's office. And I don't know if you can speak to that, particularly in terms of these questions that we've had about you know, sort of the patient interface with your, you know, quality and performance measures. And
So we have 2 minutes.
I'm sorry. Yeah. You should have cut me off. And yeah.
I get asked this question a lot, obviously, and the way I've taken to answering it is the following. We have technologies that are very capable of improving the quality of care that people get, reducing medication errors, improving the compliance with guidelines, proven care guidelines. But they're not good enough yet for physicians, particularly physicians of a certain age, to be comfortable.
Right.
So my kids are both residents in medicine. They've forgotten how to write. They've never learned how to write a note, really. They couldn't do anything but use an electronic health record. They're in that sense, they're disabled, right? Now my son's handwriting is so awful that it's no loss. But this isn't an issue for them. You know, it's people who are transitioning from the paper world. And I know a lot about what Duke is doing, because one of the jobs I had before I went to the Commonwealth was to do what Duke is doing at Harvard. And we chose that thing. We chose it, I think, for very good reasons. I do think that in 3 to 5 years, your faculty will be very comfortable with it. The problems that they have with interacting with patients are multi-causal. One is frequently the rooms in which they sit are not designed for an electronic health record. So I go into, when I was the national coordinator, I went to a lot of site visits, and I would walk into rooms where the computer screen required that the physicians turn their back to the patient. And that always struck me as insane, literally insane. I used an electronic health record as a primary care physician, and I would have it positioned so that we could look at the record together. And I could say, look at over time what's happening to your cholesterol. I could never do that in the paper world because it was each cholesterol determination was on a separate piece of paper in an unorganized sheet of papers in a manila folder. And half the time it would slip off my lap and spread out all over the room, and I'd spend my time trying to bring it back together. So I think there's an enormously powerful consumer educational and empowering tool in that record if the ergonomics can be made. And then there's this issue of entering the data. That is, I think at this point, until we have better voice recognition software, and we will. I promise you that in 5 years, everyone's going to be speaking to their computer instead of typing to their computer. But, and you can already do it with Siri, right? And Watson can win Jeopardy, with voice recognition. There's just no reason why we can't do that in medicine. We haven't because we're still at a very primitive technical stage. But in the interim, there will be this difficult transition where physicians are going to complain a lot about this problem. And patients are going to understand and see that their physicians are distracted. I still think it's worth it.
Hope so.
I'm quite convinced it is. The public health value, the quality value, the safety improvements are pretty well demonstrated. And we can't get to those performance improvements that we want without information